Hello. Hi, my name is Dr. Saud Khan. I'm a neurologist at Titus Regional Medical Center. Today we're going to cover migraine headaches and other headaches. So this will be a vast topic in terms of the headache management. Please listen to the lecture, and if any question comes into, please text in the questions so that we can answer it in the end. So there is one thing which we learn in medicine and neurology. The patient comes to hospital or doctor when they are in pain. When the elephant is sitting on your chest, you come to hospital just to make sure you are not having MI. Same goes to the headaches. When you are having a headache in pain, that will bring you to your hospital or in the clinic. So what is a headache? Headache is defined as a pain in different part of the brain or the whole brain structures, which could be receptive, could be causing these pain. And there are different kinds of headaches are there. The most common headache which we come across is tension type headaches. Yes, 70%, 35%, one of the studies have shown that tension type is the most common. So how did we define the tension type according to IHS criteria? The tension type headache is defined as having a band-like sensation, the pain, which could be mild to moderate. It can be both side, and still you can do physical activity, and it is not aggravated by physical activity. That is the most common cause of headache is tension type. We all have it. We take Tylenol, sometimes ibuprofen, we try to relax, we do massage, and usually goes away. Most of the time, there is a muscle thickness in the forehead, muscle thickness here, muscle thickness in the neck. There's some cramping is going on, muscle spasms is going on because we are stressed out. Sometimes the causes are sleep deprivation, some other stress going on in our life, and we are not doing enough exercise and we are not relaxing ourselves. So that's the most common reason we are having headaches in our life. Patient doesn't come to the hospital or doesn't come to the doctors because we take care of it with some different regimen at home. What is the second most common cause of the headaches? Sometimes we get sinus headaches. The sinuses in the frontal, maxillary, ethmoid sinuses, we have some congestion going on, little bit fever is going on, and we know some runny nose is there, and we try to take some steam inhalation, sometimes some antibiotic coverage by the primary care physician, sometimes medical dose pack, and we resolve our sinus headaches. Sometime, if you look at the data, literature, the sinus headaches can be due to sinus migraine headaches causing it. There is a mechanism is there that behind the sinuses, there are nerves are there which are irritating because of sinus inflammation, which can be triggering a migraine headaches. But that's a concept for research studies. But still, first we have to treat the sinuses with some regimen, and still you are having headache after the sinus treatment, then could be the migraine headaches, could be cause of it or associated with it. So there is that terminology we use it. Now we come for other reasons. So what are the other reasons patient comes to our clinic and providers or sometime in the hospital? We're going to deal it within these two different scenarios. So when is the headache is a life-threatening indication or life-threatening situation where we need to order the imaging, CTs or MRI. Anytime, any patient, whatever the history is, if the patient is having sudden onset of headache, we are talking about sudden, meaning seconds, then it's not migraine, it's not tension, it is something is going on with the vessel. Life-threatening, worst headache of my life. That could be, again, aneurysm rupture. So sudden onset, we need to do imaging. Sometime on the examination, if we are finding some neurological abnormalities, if the patient has dilated pupil with the headaches, then it is third nerve palsy is coming, and dilated pupil non-reactive, and limited extraocular movements. Again, that's abnormal neurological sign. We need to do STAT CT, CTA, making sure there is no PCOM aneurysm is coming. Um, Onset is sudden, and also sometimes systemic disease if it is involved. If the patient is having some type of HIV or sometime other lymphoma and patient is having new onset of headaches, we should do imaging. Sometime occipital presentation, protuberance, headache, sudden onset, then we need to do imaging, making sure there is no other secondary cause here. Okay? Sometime we have to make sure there is no progressive headaches. We are giving them medications for migraine. Patient is not responsive. The headache is still frequent and intense, non-responsive. Then imaging is indicated. Sometime positional. If the patient is moving the head, neck, and having headache, sometimes we can have cervical dislocation. Sometimes C2 nerves could be compressing it and causing the headache. So we need to do imaging in that case. Sometimes we can have other pattern changes. The headache is there, but it is not following a pattern of tension type headache, is not following a pattern of sinus headache, is not following a pattern of migraine headache. Then we have to do imaging in those cases. Any primary systemic illness, we need to have a low threshold to order the imaging, CTs and MRIs. So these are the signs where we don't want to miss it. So these are the indication where secondary headaches is going on. All right, let's come with the main topic, the migraine. So migraine is defined as, according to IHS criteria, anytime patient is having 5 headaches, which is periorbital pulsating, unilateral, and they are severe headaches, and they cannot do any exercise with that headache. So that 2 out of 4 criteria is meeting the criteria for migraine. The other things, it could be present. Nausea, vomiting can be present, or photophobia, phonophobia can be present. But all we need is unilateral, pulsating, and severe headaches. The classic situation is if you go see patient will be in the dark room, they will be talking very low tone because the voice is bothering them. And then they will not be able to move. There will be kinosophobia. They cannot smell. Again, any smell can cause this headaches for them. So they will be very much static. So that is known as migraine headaches mainly. That's a criteria. So what are the stats? What are the epidemiology and demographics? 1 billion people have migraine in the world. 1 billion out of 8 billions. So just imagine. If you look at the US stats, 18% of the female have been diagnosed with migraine, while male around 6%. I'm not so sure these are the right numbers. I think it is underestimation. I think there are a lot of time patients diagnose themselves with the help of Dr. Google, and they do not come to the doctor or others, and so we are not picking up their diagnosis. So what are the different kinds of migraines? So migraines without aura is more common, and then migraine with aura. This is another kind where the aura can be defined as any symptoms which can occur before the migraine headaches, actual headaches. So what is aura? So aura is defined as it starts from glutamate and potassium cortical spreading depression start from occipital lobes and comes to the anterior lobe. So it's not a blood flow, so it's all about chemicals, and that is causing the symptoms. So, for example, patients can have occipital lobe aura. They can have some fortification, some shimmering, some zigzag lines, photopsia, scotomas, black dots coming because all that electrical cortical spreading depression is going from occipital lobe to the sensory cortex. then these patients can have face numbness followed by arm numbness, and then if aura goes to the motor, then it could be motor symptom, facial weakness or arm weakness. But there is a key point with that the aura comes within 5 minutes. In some studies have done 5 minutes, and some studies is 4 minutes. It's a slow progression as compared to the stroke patient, where patient will have sudden, within a second, within a minute, they will have face, arm numbness. So that's the best way to differentiate it. So they can have 5 minutes progression of lights, shimmering lights, the all zigzag lines, colorful. Then they can have facial numbness, and that 5 minutes and that aura should be ended in 60 minutes. It should be reversed. This patient should be normal. So migraine with aura, we need to have 2 headaches with aura in the lifetime. While migraine without aura, we need 5. So the more data we get it from the patient, our diagnosis becomes stronger. So taking a good history becomes very important. It runs in the family, but we do not have any Mendelian inheritance in a way. But you will see that mainly mother has it, then the kids also have that. So usually it is defined as 4 to 72 hours, pulsating headaches. So aura first, migraine with aura will happen first. Then it will be followed by 4 to 72 hours, throbbing or pulsating headaches on one side, and it will be severe, and it can be associated with some nausea, vomiting, photophobia, phonophobia. And that becomes migraine with aura. But aura should be reversed in 60 minutes. If it is not reversing, then we are talking about some other pathology. So we have to be careful. And anytime in the hospital, in the ER, we come across this type of situation. Patient is having some visual issues, blindness episode. The aura should be in from both eyes. The shimmering, all those black dots should be, if you close one eye, it should not be. If it is present, then it is more likely not an aura. It is maybe eye pathology is going on, and we have to make sure there is no other kind of migraine, which we're going to discuss about it. So we have to be careful with this type of situation, especially with the aura. And when we come across in this situation, and we really cannot pinpoint because patient doesn't read the books, and they give us the best symptoms at that time, and we are losing the vision. If there is no contraindication, sometimes we treat those with a TNK, because if we miss vision issue, then we are talking about big time disability. And if it is a migraine headache, so that should not be an issue, for those situations. But again, history gives us a diagnosis. So eventually, next time patient will have the same type of episode. So what is the pathophysiology? How does this occur, the migraine? Why does it occur in some people, and why does it not occur in other people? Again, there is some research has been done, and a lot of data has been done that migraine personalities are very sensitive personalities, in the best way we can put it in. They will be one of those people, they can even notice a little weather changes, and sometimes they can be very, very OCD type. They want black and white everything. And because whatever it is, this is association. We are not talking about cause and effect. There could be some triggers which could be causing these migraine headaches. The most common triggers in most of the migraine patients are sleep deprivation. Sometimes alcohol could be cause. Sometimes, weather changes. Sometimes people talk about the weather is changing and all the atmospheric pressure is changing, and that could be the cause. And different foods containing MSG could be the trigger. Sometimes red wine, people talk about it, but different triggers for different people. And it is one of the research has shown we should not be preoccupied too much with the triggers, because in those patients, if you see those are the triggers, Sometimes 50% trigger will cause the migraine, and sometime it won't in 50% of the time. So yes, trigger could be causing it, but there might be some other chemistry going on. So this is amazing neurology in last, I must say, 40 years. Migraine, we have done so much research. When I was graduating from medical school, at that time we were taught how what it was the mechanism of migraine. So at that time we were talking about vascular theory about migraine. So vascular theory was that somehow before the migraine, the patients have vasodilatations. There is a serotonin, platelets get aggregation, and then serotonin is released. And that caused vasodilatation and vasoconstriction. So that was in 1980s or 1990s we are talking about early. But nowadays, with the help of bench research, we know there are different things are going on. It's very funny that if you look at the books at that time, they were saying that this is the vascular theory is much is more reliable than any other theory. Which other theory was neuroinflammation theory, and based on that theory, the medication of triptans, sumatriptans, and DHE was research was done, and we were using the triptans vasoconstriction to control the headaches. But nowadays, based on the new research, we know the mechanism that in some patients there is a stressor comes into, maybe sleep deprivation. After sleep deprivation, the next day there is a parasympathetic activity. It activates that parasympathetic nervous system, and then superior salivary nucleus, it secretes different inflammatory markers, which includes mast cells, histamine, CGRP, and there are some other chemicals are going on which we are discovering. PACAP, another chemical. Those chemicals are released. They goes to meningeal blood vessels right at the surface, in these locations mainly, and they sensitizes the meningeal vessels, and they start throbbing. So when these things are released, the premonitory symptoms of migraine can come into. So there is a graph you will see that one day before the patient will have migraine, they will have food craving, they will feel fatigue, and then hypoglycemic, and the next day they will develop the migraine. So these meningeal vessels are super sensitized with those inflammatory chemicals which were released from superior salivary nucleus, which was released because of the parasympathetic nervous system activation, which happened due to the stressor of sleep deprivation. And then these meningeal vessels, which are super sensitive, they go back to the feedback system from trigeminal nerves inside the trigeminal nucleus caudalis, and trigeminal nucleus caudalis in the brainstem. Then it goes back to the feedback mechanism again to the thalamus, to the VPM, ventromedial nucleus of the thalamus, and then thalamus inside goes to the insular cortex and to the frontal lobe, where the pain perception comes into. So it's a bigger circuit is there. So that's the theory, that how the stress factors, whether it's sleep deprivation, whether it is sometimes circadian rhythm, sleep deprivation can cause migraine headaches. I have gone through that personal experience. And that's the cascade start. And once that is done, we are talking about the peripheral sensitization mechanism and central sensitization mechanism. And the concept is, once the nerves are irritated, painful receptors are being again and again causing the migraine headaches for 4 hours, 72 hours, then we are talking about electrical shocks, electrical short circuit, and that is causing super sensitivity, central sensitization, and keep on having the same pain symptoms. So these are the different mechanisms which we know. So one was cortical spreading depression, which we already talked about it. One is we know that due to this chemicals, neuroinflammatory markers are released, and we all are using CGRP, anti-CGRP antibodies, and then neurokinin, substance P, and PACA, and then another is sometimes vessels are super sensitized. So that's the theory which we believe at this time. So what is the this is the main mechanism there. What are the other things which we need to worry about it when we are dealing with the migraine headaches? So migraine headaches, we already talked about the premonitory symptoms and then actual headaches, and then ultimately patient is fatigued. These are the 24-hour day graph which we review. Sometimes migraine patients have allodynia, and allodynia is defined as when they are having migraine headaches and the episode is over after 72 hours, then those migraine patients cannot calm because it is so super sensitive. Calming can be painful process, and that is known as allodynia, and it is the same concept of peripheral sensitization. Triggers, we already discussed about it. And then in other, sometimes migraine headaches, we need to think about some other differentials too. In some patients, it will be classic history. They come to your clinic, examination is normal, history is very much classic. Migraine without aura is more common. You start the medications. And then Topamax is usually the first kind of medication we try. And once they come back and the headaches get better, it's okay to continue the treatment. But sometimes they are not responding, then there are other animals we need to think about it. Sometimes patients are having different kinds of headaches along with migraine headaches. So let's suppose migraine headache is there and they come, and after 72 hours, we gave them different treatments and they are still having migraine, then ultimately they are not able to sleep. So with the migraine headache, they can also have tension type headache coming into. So there is a comorbid condition is coming. So unfortunately, we want to keep one disease for one patient, but when the patient is not responding and it is intractable, then patient get the other types of kind of headaches too. So tension type headache could be part of it. And other sometimes when we are using too many medications, if we are using Tylenol every day for the headache management and more than 3 headaches per week, or triptans, we are using it more than 3 weeks, per week, then we can have medication overuse headaches. Medication overuse headache is defined as that whatever the medication I'm taking, if I'm taking ibuprofen and that controls the headaches and take away the headache for few, maybe 1 day, 2 days, and the headache comes back, I have to take the ibuprofen again. And the theory is as soon as the ibuprofen level goes down from my serum, blood level, I will get the headache again and have to take the medication to bring the ibuprofen level up. And the key point is the headaches could be around, if we are taking the medication more than 2 times per week. So whatever the abortive treatment we try to keep the limit, maybe eight tablets per month at most, whether it is Tylenol, ibuprofen. Furosemide is one of the notorious medication. American Academy of Neurology don't want to use that medication because that's the medication causes medication overuse headaches. Even triptan can cause it too, but we have to keep a limit. There's a key there. So what is the episodic migraine? Episodic migraine is anytime patient is having this headaches less than 4 headaches per month, it is episodic migraine. We usually start the preventive medication after 4 headaches per month. What is chronic migraine? Chronic migraine is defined as if the patient is having chronic more than 15 days in a month where they are having headaches, then that is a chronic migraine headaches. Another terminology in the literature, you will see chronic daily headache or transform migraine. It's the same concept with chronic migraine, 15 days in a month, that is defined as chronic migraine. Another animal is a vestibular migraine. So there are some patients who will have only dizziness, off balance, feeling dizzy, light headache, lasting for 4 to 72 hours and then goes away. They do not get the headaches. But in those cases, we have to have a good ENT evaluations, making sure there is no peripheral cause or central cause there, MRI of the brain stems, and if everything comes negative, then that usually is a diagnosis of exclusion, the vestibular migraine. Another entity is known as ophthalmic or retinal migraine. Same pathophysiology. We think that there is a vasoconstriction of the retinal artery for a few minutes, causes the darkness in one eye, and then it vasodilate, and the vision come back. Again, we have to follow the process, eye examination, making sure there is no eye problem, and that will be the retinal migraine. Sometimes in the literature you will see silent migraine. Silent migraine will be where you will not get the headaches, but you can get some other symptoms. That is the definition of the silent migraine. So sometimes nausea, dizziness can be classified in that case. Another entity in the literature you will see menstrual migraine. So during the menses, especially when the estrogen level goes down, the patient can have migraine episode in those cases, but sometimes in those patients, even migraine can occur without menstrual situation. Status migrainosus is defined as, again, 4 to 72 hours, one-sided, unilateral, pulsating, photophobia, phonophobia, nausea, and severe headaches, unable to stand up, walk. And the typical is in the hospital, in the ER, they will come, and within few seconds, when you walk in the room, you will see dark room is there. You will see the towel is on one side, and they are having severe headaches. They will not be walking. If they're walking, then it's very unlikely migraine headache, but there could be variant too. But then sometimes it could be tension type headaches. The best way to differentiate between the tension type headaches and migraine headache is that whether they can do any exercise. If they are able to do exercise, climbing the stairs or walking, talking, and some running, then it is unlikely it's a migraine there. All right. There is another entity known as migraine with brainstem aura. In that patient will present with some dizziness, lightheaded feeling, tinnitus, numbness in both hands, legs. Start from the aura. So we are talking about 5 minutes to 60 minutes rule, and it should be reversed. But until prove otherwise, if it is a stroke, until prove otherwise. So we're not going to wait in this situation. Where if we think this could be the stroke, then we usually give the TNK. But it's all about good history. If the patient already has a history of 2 incidents of aura, then maybe it is the situation. Another migraine is defined in literature, abdominal migraine. Sometimes patient only present with nausea and vomiting. They do all the workup of gastroenterology, and nothing is found pathology. So all they are having is nausea and vomiting. But it should be cyclic. It should end over after 4 to 72 hours, 3 days. All right. Another migraine situation literature is familial hemiplegic migraine. And there is a literature where in some patients, patient can present with headache and one-sided weakness lasting for a day, and then it can resolve. It's very rare. Let me tell you just here, most of the time when we see our patients, they have the headaches plus they have the numbness episode, and they use a crawling sensation or marching sensation. So rule is 5 minutes to develop, and then marching sensation, meaning 20 minutes here, 20 minutes here in the arm, 20 minutes in the arm, torso and leg. And that is very classic. But again, patient do not follow the book. So in that situation, whatever the patient is giving the history, we have to just believe it. One more thing I would like to point out, since we neurologists take care of the stroke patients, when we see the patients in the ER or in the clinic, we let the patient talk and we do not intervene. And whatever the first few minutes when the patient is talking, they are usually giving the relevant information. But sometimes we have to give them direct or indirect questions, and we try to get the information, let them talk and see what is coming. But when we are trying to get some more information, and if we are putting the words in their mouth, the history get contaminated. So whenever we are trying to make a final conclusion, we have to see how the information has come. Did we push the patient to get that history which I wanted? And sometimes we all have a sin of greed. We want that information to make a diagnosis. So first few minutes are very important, whether we see in the clinic, whether we see in the hospital. Let the patient talk. Please do not interrupt and see what are they saying. Sometimes they have cognitive disorder. Sometimes they are not giving us the good history because of the cognitive issues. Then in that case, we have to get information. But when we are getting that information, when we are trying to conclude, please keep that thing in our mind, that the information which we got it is false information. So maybe right, maybe it's real, maybe it's not real. So that's the thing which we have to avoid, have to be careful. Another entity we come across in the literature is a cluster migraine. So cluster migraine is defined as classic history of the cluster migraine. 40 years old male, have a alcoholic binge, drinks alcohol, and at the middle night at 2 o'clock, he will wake up. He will have cluster of migraine right inside one periorbital region. So he will be like having boring sensation in the eye at 2 a.m. and he will be restless. He will be pacing here and there. He's having pain. He will have a ptosis. He will have a meiosis, and he will be very restless. That's a classic history. The next day, the headache will last for 15 minutes to 180 minutes, and it will resolve on its own, whether you do it or not, if you survive that first bout. But then it can occur again the next day, same time, 2 a.m. So it's like a clock. At the same time, he will have the same type of episode. So they will give you the classic history. And usually they can be treated with oxygen, sometimes calcium channels, sometimes steroids. Meteral dose pack steroids can be given in those patients. So when the biggest difference between the cluster migraine and other migraine, these patients are restless, pacing. They are having a boring pain in the eye. All right. Another differential in the migraine headaches, there is a SUNCT, sudden unilateral onset of neuralgiform. It's sudden unilateral neuralgiform connective. It's tearing and congestion. Sorry. So it's a very rare disease, headaches. It will last for 30 seconds to 45 seconds. Very rare. The patient will have only congestion in the eye, the chemosis, especially in the sclera, and a little bit tearing will be coming, and then some congestion. And the key point for that diagnosis is it will last for a few seconds, and there will be multiple headaches episodes. Another very rare headaches is paroxysmal hemicrania. Paroxysmal hemicrania is defined as when we have one-sided headaches, can last for 30 minutes, headaches and plus sometimes neck, and sometimes they will have autonomic nervous system in the eye, some eye tearing, some nasal congestion, but the key point is 30 minutes and multiple in one day. So the differentiation between migraine and these headaches is migraine is a constant headache for 4 to 72 hours. The SUNCT was lasting for a few seconds. This one was lasting for 30 minutes. And another variant of paroxysmal hemicrania is hemicrania continua, when same paroxysmal hemicrania is there, one-sided, tearing everything for days, and usually they are only responsive to indomethacin. But then sometimes in those patients, we can also try steroids, middle dose pack, and sometimes we can try verapamil, calcium channel blockers. Another headache in the literature has been reported is hypnic headaches. Hypnic headaches, whenever our elderly patient, 70 years old guy, wake up in the middle of night at 2 a.m. and having a severe headaches on one side, never had the headaches before, no history of migraine, nothing, and usually they respond to lithium. All their workup comes negative. Another headache is exertional headaches. In the literature, they find patients is having some type of exercise, we become doing the weightlifting, some sexual intercourse, and all of a sudden they will have a sudden onset of headaches. We do all the workup, MRI, CT, CTA, spinal tap, everything comes negative, no subarachnoid hemorrhage, and then ultimately it will be exertional headaches. And usually indomethacin can be a medication. But again, we have to follow the process. We want to make sure there is no secondary cause. We want to make sure there is no subarachnoid hemorrhage, sentinel bleed, aneurysm rupture, all those stuff. So these are the main things in the literature we come across in terms of the migraine headaches. So let's come back with the situation in practical approach. How do we take care of these patients? So first of all, these patients shows up in primary care physician, and usually primary care physicians are very smart. They are able to diagnose whether it is tension type versus migraine, and they do give some kind of trial of the medications. Most of the time when they come to our clinic, all the things have been done. And we classically, history give us a diagnosis. We start the patient on Topamax. We try to build up slowly. We start 25 milligram at bedtime. And then on every 3 to 6 weeks, we should see some improvement. In neurology, most of the migraine medication takes time. It takes at least 3 to 6 weeks. On the first visit, we are very much, we put the reality. We say that the headache will not go away. This is a short circuit going on in our brain. We need to slow it down. So the major things which we have to do, lifestyle modification, is having a good sleep, deep sleep, and exercise. And watching your triggers, what are the things which are causing it. And then with the help of the medication, we will try to slow down that short circuiting which has been going on. So we build up the Topamax from 25 to 50 to 75. Most of the time, 50 to 75 milligram at bedtime usually is good enough for the migraine prevention. Possible side effects we discussed on the first visit. It can cause weight loss. It can cause sometimes kidney stones. But if patient drink a lot of water, then we can avoid the kidney stones. Sometimes numbness of the fingers can happen. We also, in some patients, patient already has a kidney stones, and that is usually gone. It is not there anymore. And they do want to try this medication. So in that special situation, we do the informed consent and written consent that we will try the Topamax, but we will do annual ultrasound just to keep an eye on those kidney stones. So that's the first medication we try in our clinic. Let's say in best scenario, the patient helps, headaches goes down. Then we also recommend lifestyle modification, good sleep, plus good exercise. So we should have enough exercise, enough during the daytime that when we go hit the bed, we should be able to hit the deep sleep. And you guys might be knowing it nowadays, even AHA came up with the Lifestyle 8, in which they are recommending having a good sleep is a very important part. So we try to do the lifestyle modification with some medications. If headache is getting better after 6 months to 1 year, we can take off the Topamax and we just educate the patient. Lifestyle modification, watching the triggers, just making sure you are good doing exercise and having a good sleep, we can prevent it. That's the best clinical scenario in the clinic. But let's come up with the worst clinical scenario in the clinic. So you try Topamax, patients 3 weeks, 6 weeks, and you maximize it after every 3 to 6 weeks, and you are not getting the result. headache is still there. And before you starting the medication, you want to see the comorbid complaints, and also you want to know the comorbid problems. If the patient is depressed, sometimes even Topamax depression can help. But sometimes, amitriptyline, nortriptyline can help the depression plus help the sleep too. So if Topamax is not working, sometimes we switch over or add on. If there is no effect, then usually we will switch over to amitriptyline or nortriptyline and try to maximize it. Again, we start very low, 10 milligram, go and 3 to 6 weeks follow up. Then we go to 10 milligram, 25 milligram of amitriptyline, then 50, then 75. 75 is the maximum most of the time, because the more higher we go, we will be getting some side effects, especially the anticholinergic side effect. They can have some memory issues, memory lapses, and brain fog. So we want to avoid that. Nortriptyline has least side effects, but nortriptyline does not have the more data in headache world as compared to painful neuropathies. One of the best medication which my mentor educated me on that was the doxepin. So when the amitriptyline doesn't work, we usually switch over to doxepin. Doxepin is a little bit stronger in sedation and usually give a good sleep. 25 milligram, sometime we start with, again, 3 to 6 week follow-up from 25 to 50, 50 to 75. And around that time, we should be able to take care of it. If that doesn't work, for example, let's say worst situation, then the next thing is usually Inderol. If the blood pressure is there, we can try that. Sometime if there is a bipolar disorder, mood issues there, then we can try valproic acid. And if we are meeting the criteria for chronic migraine, we can also try the Botox shots. We also try newer medications. In the beginning, the insurance company, we were having some difficulty in prescribing those medications, but nowadays I think most of the time we are able to get CGRP medications. So CGRP is anti-CGRP medications. It works on the antibodies, especially the protein CGRP, plus it is working on the receptors. If you look at the research data, it works 60% of the time, and still we are missing 40% of the time. So there's one good study came, I think, last year, that in patients where CGRP doesn't work, there is another protein discovered in research known as PACAP, PACAP, which is pituitary adenylase cyclase protein. And that is as similar as CGRP, which is causing the headache. And the patient who didn't respond to CGRP, they were given antibodies against PACAP, and they responded very well. So sooner or later, I think we will be hearing about their medication. So we go for Botox shots, sometimes neuromodifications. There are some different types of magnets are there. We can try that too. So this is a chronic migraine, intractable migraine we are talking about, and all these are the regimen we try. Most of the time when we see the chronic daily headache, meaning headaches more than 15 days in a month, they are usually combination of chronic migraine, complicated by chronic tension type, and we are talking about depression coming in. And again, whether cause and effect, we do not know which thing caused which, but headaches is not well controlled, they cannot sleep, and then ultimately they are having these type of symptoms. All right. Now, coming up in the hospital setting, let's say the hospital setting patient comes with the headache. In the ER, patient is having the classic in the ER dark room, cold towel is there. I have a history of migraine headaches. We give usually magnesium sulfate to break the cycle of the headaches. Our ER physicians are very smart. They already give the Toradol, Benadryl, all those medication, and promethazine to break the cycle. But by the time we are consulted, we usually try magnesium sulfate. We usually try Solimedrol, sometimes Dapacon. These are the medications. And when we were graduating in 2005, We were keeping our migraine headaches, status migrainosis patient in the hospital for 5 to 7 days. At that time, insurance company were not giving us a hard time. Let's put it this way. And at that time, we were doing the rescue protocol. One of my mentor, Dr. James Couch, we used to give dihydroergotamine, very smaller dose, 0.1 milligrams. We start with and 1 milligram every Q8 hours with rescue protocol of doxepin 25 milligram, Q6 hours to Q4 hours, hold for sedation, and let the patient sleep for 3 days, 2 or 3 days, breaking the cycle of the headaches. It was working in those patients, but if you look at the side effects or contraindication for the medication, DHE, we cannot give it in stroke patients. We cannot give it in heart attack patients, cerebrovascular disease. We cannot give it renal impairment. We cannot give hepatic impairment, and then it can cause retroperitoneal fibrosis. So usually we were prescribing it, but then, all things came that migraine can be managed as an outpatient in the infusion clinic, all those stuff. So we have deviated from that protocol. But it works in some patients. But we have to be very, very careful if they are having any heart problems or any stroke issues. And let's say if that doesn't work and patient get admitted, and now this patient is not responding to different medications, different protocol, and patient still having headaches and photophobia, or even not photophobia and unresponsive. The next step in the inpatient, we usually do spinal tap. And the reason we do spinal tap, because sometimes if you look at it, we have aseptic meningitis, which could be causing these headaches, So we all went through a COVID era. So much we learned from that. So there are different viruses out there which can hit us, and they can have a severe headaches, and that's it, nothing else, no other symptoms. In those patients, when we do the spinal tap, we can come across severe headaches, little bit CSF white count, little bit, no other differential, normal glucose and protein, and usually we can think maybe it is viral and aseptic meningitis causing the headaches. So that could be. So migraine patient can have aseptic meningitis or viral meningitis. So in that case, usually again, sometimes pain medications, and sometimes again, sleeping is a very, very good phenomena. We would like to let them sleep. Doxepin we try. We used to try Stadol for this type of situation, but again, American Academy of Neurology doesn't like to use the opioids. In a special situation, when we have to break the cycle of the headaches, we have to shut down this machine which is causing the headaches. Sometimes doxepin can work. Sometimes we have to use Stadol, and no other choices there. So let's say this patient is having this aseptic meningitis. Doxepin can work. We can sometimes add on Topamax, sometimes simple magnesium, riboflavin, multivitamins, and that patient can be discharged. Let's say that you do the spinal tap, and the spinal tap is negative, and then ultimately you take care of the headaches with some pain medication and everything, and then you can come up, and this patient comes to your clinic, and that patient says that from that day I had the headaches, I'm having that headache and it hasn't gone away. Then we created a new terminology, and we came up with newly persistent daily headaches. So when you see the newly persistent daily headache, the patient will remember on that day, from that day, I'm having headaches and it has never gone away. I never had the headaches. But if you review the literature data, these patients are turn out to be either they are having depression, or they are going through the divorce situation, and they are having either chronic migraine or chronic tension type phenotypes. So that's how we have classified it. So I think we have gone through the whole best clinical scenario, worst clinical scenario in the clinic and in the hospital. I think there might be some questions. If you guys have, please ask me. So there will be few things. These are practical approaches which we try to do it in the clinic and in the hospital.
All right, Dr. Khan, we've had a few questions come in through the chat. So we'll start at the top with the first one we have from Nikki McGee. She says that she wants to know how to tell between migraine and stroke when there are vision changes and weakness.
Very good questions. So if the patient has read the book and giving a good history of within a second, that I got a vision loss within a second. So that's why I ask, what exactly happened? They say I lost a vision within a second, maybe less than a minute. Then it is a stroke until prove otherwise. But if they are giving me a history that before I lost a vision, I was having these scintillating scotomas, some rarefactions, some zigzag line, and then it developed. After 5 minutes, then it got dark. Now I'm here. Then it's a very classic history. Okay, but in this era, in 2025, when our mentors wrote the books, at that time patient didn't have the internet. Now patient have the internet. They have already read the Dr. Google. So we have to be very, very careful. Is it they are giving me classic history, or they have read the Dr. Google and now they are giving me that? And again, there is nothing wrong with that, but we have to be careful. In that situation, when I'm iffy 50-50% and there is no contraindication, I will give TNK in those cases. I don't want to lose the vision here.
All right, the next question actually came from Bobby. He wants to know, he says, we've all seen the TV commercials, but is Botox an effective treatment for migraines?
Yes, Botox is effective in chronic migraine only. When the patient is having 15 days per month, they meet the criteria for chronic migraine, and now it is approved. In the past, it was not approved. So yeah, we have gone through this. First study, second study was negative for Botox shots for the chronic migraine, but eventually we saw that yes, it does help.
The last question we had was from Kim Isaacs, but she said that she believed it had already been answered, but I just wanted to make sure that that you didn't have anything to add. She asked what medication combinations can best treat the patient during their migraine. So did you have anything else you wanted to add to that, or do you feel like you covered that pretty well already?
I did, but again, I think it's all about look at as a patient, the whole patient. If you think the patient is thin and they're not obese, then I will use amitriptyline first, I will not use Topamax, okay? But if they're obese, then I will go for Topamax because that can help their obesity too. But again, with comorbid condition, we have to see depression, all other things, we have to address those. It goes Topamax first nowadays, plus it goes, then we go for propranolol, we go for valproic acid, and then CGRPs. These are the main medications in terms of chronic migraine management.
Well, that covers all the questions that we've had. Thank you, Dr. Khan, very much for coming in and talking with us today.
Thank you.